listened to variations of this presentation twice, 3 times now from various colleagues of Professor Fuall's. And we're very honoured today to have Professor Fuall talking to us about this particular project that the Lean Institute Africa has been involved in. From a SAPICS perspective, so I represent SAPICS and also the Iaphl South Africa chapter. And SAPICS's drive really is to work with like-minded associations here in South Africa who are working towards professionalizing supply chain management, educating people working in the profession to be able to do this incredibly important role to the best of their ability. I've known Norman for many, many, many years, and I've watched the Lean Institute Africa grow in stature, in the projects that it's doing. There is innumerable amount of work that's being done in the public health sector, which I'm quite sure that this current audience today is going to be really, really interested in. Even if you're not in the public health sector, you will hopefully have had the privilege of having a vaccine, and it will be interesting for you to know exactly what goes on behind it and the continuous improvements that are being put in place. So I'm going to ask Elaine if she wouldn't mind putting the email, the website address for the Lean Institute Africa in the chat. And then when you have a moment, please have a look. Please have a look at all they do. Iaphl also will send you all information about Iaphl if you're not already a member. We'll put the link into the chat as well. And we encourage you to become a member of Iaphl and particularly of the South Africa chapter. We're trying to grow it. We're a bit slow. We're working hard at it, and we encourage all participation and involvement. It's really important. Community we've seen in the last 2 years is everything. So without any more waffle from me, I promised I'd keep it short and I've managed to waffle. Norman, over to you. And please remember everyone, comments, chat, please put them in your chat and we'll discuss them if we have time later.
Thanks very much, Jenny, and hello to everybody. I also want to tell you that I'm accompanied by Dominique Boswell today. She's the senior pharmacist based at the Cape Town International Conference Center, which has been repurposed as a mass vaccination site. And we're sitting in the site manager's office, which is why you'll see some illustrations on the wall behind us. Dominique will be contributing more detail later in the presentation. I know supply chain people like to talk about the last mile. Well, we're going to give you the last 80 meters or so. No, it's not progressing. Okay, I just want to give a couple of acknowledgements up front. This vaccination program, I'm sure you all appreciate, has been involved international agencies like the World Health Organization, and they put out vaccine toolkits and guidelines, and the South African National Department of Health in May this year put out a very detailed implementation guide and toolkit, which I'll be drawing on quite extensively. So I think you're all familiar with the vaccine supply chain. It has an international component and a national component, and we are obviously going to focus on the national component. And this is an illustration taken from the National Department of Health guide and toolkit. And we're going to start with the primary vaccination site. And then that site will distribute to secondary sites like the Cape Town International Conference Center and the Iaphl Stadium, which is the other site we'll mention. There are also temporary outreach services, and Dominique at the moment is supplying one at the Groote Hospital. Of course, that again complicates her work operating more than one site at a time. We won't be talking about mobile services, but they do exist, and another supply chain complexity. So this was the very simple front page of the National Department of Health Implementation Guide and Toolkit. And I want to show you some pages from it which pertain to the topic of today. So you'll read through this very carefully, I'm sure. My point in showing you is that it's part of one page or nearly 100-page document and is talking about the micro planning for successful vaccine delivery. And I just want to highlight the areas that are supply chain oriented. So there is the cold chain, its equipment specifications, infrastructure needed. Then the numerous other things needed to support a vaccination process. I wouldn't be surprised if, in addition to the vaccine, there are 100 other things that come into play. Cotton swabs, needles, syringes, infection control, just an enormous number of things. And on the site, an emergency medicine capability as well. There has to be very careful storage and handling of the vaccines. They're extremely expensive, over 400 Rand. What's that about? Whatever, divide by 10, 40, about 30, 20, $35, something like that per dose. There's also the physical distribution requirement for a vaccination program and waste disposal end to end. So this is just to give you some sense of the complexity involved in a mass vaccination campaign. And finally, you'll see when going to remote areas, dealing with farm workers, rural areas. And I've had the privilege of observing some of those activities as well. I must say I've been extraordinarily impressed by the wide range of people cooperating to make this campaign work in South Africa. And as part of our planning here, we've been able to tap into know-how in the UK and in the USA. So these are the two chapters in the implementation guide that we will be focusing on. So the vaccine management, cold chain, logistics, distribution, which Dominique will talk to in a while, and then the planning of the client journey and the actual administration of the vaccine. So this is a picture, again, from the toolkit, and it's showing the two different vaccines used in South Africa, the J&J and the Pfizer. The cold chain requirements of each are similar but different in very specific details and different expiry dates. So we'll return to that shortly when Dominique presents. So what has the Lean Institute Africa been doing? You'll see this funny word, Sisonke, come up every now and again. That was the vaccination of healthcare workers in South Africa, a campaign that began late February this year, and it used a research protocol. The vials were produced under research conditions, and the drawing of syringes were done by pharmacists. The program was rolled out at pretty short notice, and we were privileged to observe some of those sites and begin the process of understanding where bottlenecks arise, what lies behind them. That was known as Sisonke, and then in early March, the going public happened. 65 plus age group was given the go-ahead, and the Pfizer vaccine was used there. Sisonke used J&J. So we visited many of the larger sites in the Cape Town area and some rural sites and a couple of mobile sites as well. We were also observing compliance with the national protocols, although we have no medical expertise, it was simply observational. We spent a lot of time recording cycle times at the various stages in the vaccination process. We were very privileged to be involved in planning meetings once or twice a week with national and provincial level officials, up to 20 people on a call. Just extraordinary cooperation, getting on with the job, not waiting to go through lengthy procedures, but decisions made on the spot so that things could proceed. We'll be talking today about our site level focus, which was essentially to get the effective operation with the efficient use of resources. But just to give you some pictures from the sites, this is the Cape Town International Conference Center. So this is outside, people queuing, more queuing, more queuing, then coming into the building to queue for the pre-screening process. And the screening desks are over there. There was also a registration area if someone, well, there still is, if someone arrives who is not registered on the electronic vaccination system, they are able to be registered on site. And you can see a lovely large facility, open spaces. Once you've gone through the screening, you come to a registration desk where your details are checked on the electronic vaccination system. Proceed from there to the seating, which is just upstream of the actual vaccination stations. And at the CTICC, there are 5 so-called pods, 1, 2, 3, and there are 2 out of picture, with 5 cubicles per pod. So the capability to have 50 vaccinators working simultaneously. And then this is the seating in the post-vaccination area. You'll all be aware that if there are no complications expected, you will wait 15 minutes. And if complications may happen, you will wait for 30 minutes. And then supporting this whole system is the pharmacy and the adjunct facility of preparing vaccine and preparing syringes to supply the cubicles. So a very nice journey for clients and a journey for the vaccines. The other site that we were mostly involved in the design and launch of is the Iaphl Stadium, which is a sports stadium. And you can see from the photographs that it's much more exposed to the elements as one would expect from a sports stadium. People arriving, going through a screening process, going through the turnstiles and into the registration check area. And from there to the cubicles. And I think largely as a result of our recommendation, they quite significantly reduced the number of cubicles originally envisaged. So here we will see there are 22 cubicles in this long hall. This is a detail within a cubicle, and we set up a way of visually managing how many vaccination syringes were available at a desk at a time. So from the cubicles, people would go to the observation area, and again, we have the syringe filling area at the Iaphl Stadium. Iaphl also has Cape Town's only drive-through facility. So there's the stadium in the background. The stadium parking area was used. Again, where the registration is checked in these cubicles, going into this intended area, 5 areas in which the driver and passengers could be vaccinated, and then the observation area after that. This visit was a couple of days before the event, so my car is the only one sitting in the observation area. So back to the journey for the client. Again, from the field guide, 3 stages: a communications phase, an enrollment and scheduling phase, and a vaccination site activity. So up front is social mobilization and demand creation, so that people will register, enroll on the electronic vaccination system. Of course, this predates the fact that walk-ins has become the dominant mode by which people come to vaccination centers, but there is still a component of scheduling involved. And then ultimately the person arrives at the vaccination site, goes through the screening, the checking of registration details, and then the vaccination process itself. And you'll see in a moment that there's a lot of detail involved in that. Then to the observation area, and hopefully home and healthy. So this is the more detailed process within a vaccination site, that coming from the registration process into the role of the vaccinator, who confirms registration information and provides information to the person about what they're receiving and possible reactions, and gets their consent. And then the vaccination happens, the person gets an SMS, possibly immediately, but very shortly after the injection, because within the vaccination station, there is a computer which is linked to this electronic vaccination system. So that's the path that we are most interested in here at a vaccination site. That is the value adding part. That's why the whole system exists, is so that an injection can be given. And I'm highlighting this because it was a departure from the national guideline. That guideline indicated that the vaccinator should draw up the syringe, prepare the vial and draw the syringe. And that for many sites proved to be problematic, and a workaround was instituted. So here is a very simple overview of the process. This is the journey of the client, or we call them clients or patients. And this is the journey of the vial, which meets up with the client in the vaccination station for the value-adding process. This is a slide taken from one of the Excel sheets that we drew up, in which we try to create a picture of the journey. Here's the journey of the vial and the syringe. Here's the vaccination area itself. Here's a typical lean attempt to show value adding and waiting time. What I'm really wanting to illustrate here, or what became obvious to us, if the national protocol were followed, this entire process, sequence of activities, would have to be done by the vaccinator, the person who's going to give the injection. Now, quite early on in our involvement with national vaccination campaigns was information from the UK that indicated they were planning to do an injection every 90 seconds. And you'll see that in this case, the bottleneck time would be 220 seconds if things went really well, because of the multiple steps that the vaccinator would be asked to undertake. To show you a comparison of resources needed, using a process where the vaccinator is simply supplied with a syringe, as happened in the Sisonke process, one would need to achieve 2,000 jabs a day in an 8-hour day, 10 vaccinators. If one used the guideline process, it would need 43 vaccinators. You can see the total number is the same, but there's a switch in resource from administrator to nurse. And of course, nurses are a much scarcer resource. So we were involved in these two sites, large sites, Cape Town's largest two sites. And our data in the weeks and months prior to their opening indicated that the national guideline of just 50 vaccinations per vaccination station per day could be improved on. And here again is an example of where we're saying, here are our calculations, working with an 8-hour day, 80% utilization of that day, and a range of different cycle times. I remember the UK was talking about a minute. We're saying 2.5, 3.5, 4, 4.5, with 50 stations, which was the expected number of cubicles at the CTICC, and indeed the 50 were erected. And on the right-hand side is using the early national guideline of 50 vaccinations per day and 50 cubicles, one gets 2,500 vaccinations done in a day. Subsequently, the 50 was upgraded to 80, and that would give 4,000 a day. However, we felt that 2.5, based on our observations, was very feasible. So we were talking about an ability 3 times higher than that originally envisaged. But even if one simply worked with 4.5 minutes, a much slower rate, that was going to be better than the 80 per day. So here is a view of one of the, this was about a month before the CTICC opened, a floor plan. So this is the entrance. People would queue, at the peak, people were queuing almost around the building, coming around into this point, into a snaking queue to the screening desks, walking along here, into the exhibition hall, to the registration checking desks, from these desks into pre-vaccination seating. Here are the 50 cubicles in the 5 of 10 each, and here's the post-vaccination seating and exit through here. So we got involved in sizing all of these things, trying to find the balance between the rate at which people could be processed through screening, to be balanced with registration, to be balanced with the rate at which the cubicles could work, and finally ensuring that the cubicles didn't have to stop work because there was not enough seating available for people who had already been vaccinated. Once the CTICC got going, we were feverishly measuring cycle times at each of the critical points, indicating that we really needed more screening. That was really the main reason for this very long external queue. And there was also a need for more registration desks. So what we wanted to see was that the pre-vaccination seating was well used, so that the real value-adding activity would never be delayed by a shortage of clients. We also wanted to be able to manage the expectations of the people in the queue. So if you know the rate at which you're working, you can simply count the number of people in the queue, and number 100, you can tell them how long they're going to wait, and number 200, how long they're going to wait for their injection. It's a question as to whether we were right. I suspect we were right enough, but I think all of us have learned a great deal of insights about how to do this. Once the site was up and running, we were also able to support site management with a visual management system. And you can see we're sitting in the office where these photographs are taken, just illustrating the number of vaccinations per day. And then we were interested in the cycle times per pod. So the 5 different sheets there, one for each pod and the rate at which each pod was able to vaccinate people. We were also able to be involved in A3 problem solving for more systemic problems once the site had got running. And then also part of an ops meeting huddle and the huddle board to keep track of things that needed to be followed up and who was going to do what by when. So we come back to the journey of the vaccine, and I'm going to show you just one further slide. So there are many regulations, many compliances required of the vaccines. And as I hand over to Dominique, just to show you that she's managing 2 different vaccines with different conditions, and a juggling act to never overproduce or underproduce on a daily basis. Dominique, over to you.
Good afternoon, everyone. I'm Dominique, the pharmacist on site at the CTICC vaccination site. So I will just be taking you through the SOP that we have developed specifically for our site and that we have implemented and that has really worked for our site in managing and controlling our vaccines. So as Norman mentioned, the vaccines really go through a whole process. So initially, once we do receive it, we get it from our depot where it's already been thawed, and we then store it on site. So this entire process is managed by pharmacists. We then, just prior to actually preparing it, a certain amount would then be removed from the refrigerator, and obviously, like for example, with the Pfizer as well as the J&J, just in terms of prepping, it's very time sensitive. So there's all these waiting times that needs to be considered when actually prepping the vaccines. So once the vaccines are then removed, we have to wait for it to get to room temperature. It is then dispensed to our trained professional nurses in our pre-filling area, because as mentioned previously, our vaccinators don't draw this. We prepare this in an aseptic area away from the patient. So because it's quite a big site, our pre-fillers or our professional nurses, they prepare the syringes. It's packed in specific containers, labeled and then distributed by our runners to the vaccinators in one of our 5 pods. So it is quite important that there's always an even distribution and that there is always syringes available, so that by the time patients get there, that they don't have to wait that entire 15 minutes for it to get to room temperature, and then including the drawing time. And then, like I said, the entire process is overseen by myself, and this is really to ensure that the quality and accuracy of the vaccine doses is maintained throughout the process. And again, then just to note, one of the things that I've implemented with my SOP is to have tracking sheets. So I will show that in my next slide, that for each professional nurse, once I dispense vaccines to them, they need to track the exact doses that they have been able to draw from that vial. So all of these I will then track. So this is just an example of what we do here at the site. So as you can see on my left, these are the containers that we use, along with a label that is required for our administrative staff just to enter in for that specific patient. And we would usually put 1 to 2 syringes. So this would mainly be based on the demand at the site. And then on your right, those are syringes that are ready to be distributed to the various pods. So this is just the tracking sheet, so one of my tracking sheets that I've used, and I've really found value in this because just tracking each dose that we have prepared, it allows me also just to know exactly how many syringes or how many vaccines we have prepared, how many we should have. And we use this in combination with an electronic client database. So I'm always staying ahead of the amount of patients that we have already vaccinated throughout the process. So I think the main thing that I would like to focus on is how do I manage the supply of the vaccines and prevent, obviously with the vaccine process, there will always be wastage, but how do we actually prevent high wastage? So we have two systems that we use throughout the first part of our day. So that would be 8 till 2 o'clock. We do the pushing system. So we allow our professional nurses to just prepare a certain amount of vaccines ahead of time, so that by the time our clients enter, that the vaccines are ready to be used. So like I said, we use an electronic system, so I can actually monitor what the amount of vaccines that are prepared and then the amount of clients that we have already seen. It's important that this demand must be monitored continuously, because there are days where it may be slower than others. So based on the demand, we'll either prepare more or we will halt the process and allow the vaccines that we have prepared ahead of time to be utilized first. So this is just an example of the electronic client record that I was speaking about. So as you can see, it tells me exactly how many people we have completed. And then obviously up until a certain time of the day, so it's usually between 1 and 2 o'clock, I will then decide whether or not it's feasible or that we should be removing more vaccines from the fridge and preparing more, or whether the buffer of the 500 to 100 vaccines that I have created throughout the day, the first half of the day, should be used. This would then be communicated with the floor manager, and vaccines will be redistributed throughout the pods to ensure that they are used. So there's quite a lot of communication that has to happen at a mass site. And at our site specifically, we have various what we call live counts. So this usually happens between the time, as you can see on the screen, and vaccination operations are paused. So during this time, we will then just have a look at and basically count every vaccine in each of the 5 pods, as well as vaccines that have already been prepared in the pre-filling area. So this is mainly just to determine whether we have an excess of clients or vaccines. And then based on whether it is more vaccines or client, we will then first balance out the system and start preparing as patients start entering the facility again. So I just want to show you the area. So as Norman mentioned, this is where our patients enter and the pre-filling and pharmacy areas over there. So as you can see, I've got no visuals on the amount of patients in front. So it is quite important that there is a fluid communication between the operational manager and pharmacy, and also what we call the count lead. So this would be the person on the floor just managing the amount of syringes or the count on the floor. And obviously this is communicated back and forth from 2 o'clock up until 4 o'clock, the end of the day. So the second part of the system, so basically, like I mentioned, we'll then do a pulling system. So we obviously can't push vaccines because we are getting to the end of the day and the demand starts to decrease. So we'll only prep as soon as pharmacy gets contacted either by the operational manager or the account lead. So as Norman mentioned, it has been quite a juggling process to be managing 2 different vaccines simultaneously. But I think really the key points and what has been extremely important throughout this process is to have adequate communication platform with all parties involved and to have tracking mechanisms. I think even at our site, just the interdisciplinary approach ensures that we have effective processes and that we don't neglect quality in our client care. And with the COVID-19 vaccines, they have such specific condition and preparation requirements, and that needs to be adhered to. And all of this really significantly impacts how we manage and how we control the vaccines, which is quite important. So that has really been my experience so far. Thank you.
Dominique, thanks very much for that. I can't overemphasize the role that Dominique and her team have fulfilled here. What she's just described has evolved over the months. First day here was 7th of July. And she was really thrown in the deep end. And in the early days would herself be moving from her work area into counting the queues at various points, cajoling staff to help her. And it's only over time that the standard operating procedures have been developed and the disciplines required to make them work have been adopted. So this is the record. You can see doses wasted per day. Now it's 6 doses per vial. So in the early days, there was a lot of wastage, and then the system was devised and kicked in, and now it is extremely unlikely that a vial is wasted. And I think it's, as I've spoken to people at sites overseas, this has been a really difficult thing to manage. And the crew here at the CTICC must be congratulated with what they've achieved. So this was the daily email WhatsApp that I get from the site manager. And this was the one for Friday. It shows the J&J vaccines being given, no doses lost. The Pfizer vaccines, 528 doses drawn, 528 doses given, 0 wastage. Just to give you the broader South African picture, these are, this is data off the National Vaccination Information Site, and it shows the vaccinations per day from the 21st of February, the start of the Sisonke program, to the end of August. So I'm showing you now where the program was started for the Pfizer vaccinations of the 65 plus, maybe it was 60 plus age group. Then we see a real spike, first spike for the 50 plus age group on the 5th of July. That was just as the CTICC opened its doors. These are not CTICC figures, obviously, they are national figures, vaccinations per day. Then we see the really big spike when the 35-year-olds are admitted to the process on the 1st of August. And then the 18-year-olds on the 20th of August. Sadly, what I'm showing you now in that purple arrow is that the early adopters flood in the first few days after their age cohort is given the green light to arrive. But it has fallen off quite rapidly so there are a few weeks of good demand and then it declines quite rapidly. The national site is no longer reporting per day and is now reporting per week. So here is the picture from the 21st of February to the current situation. This is as of Saturday last week. So peaking at 1.1 million in a week, nearly half of that. So these drop-offs are real concerns. Here is the CTICC's own picture from its inception on the 7th of July. lots of ups and downs. Here's the 20th of August, which from the previous slide, we see the 20th of August is when the 18 plus age group came in, which 18 to 35 is where the bulk of the South African population lies. And that is where, if we're going to get to 70% of adults vaccinated, we've really got to get very good numbers in that cohort. So that was that point. This is the 12th of July, Friday last week. What we're seeing now is a very nice uptick because the health workers are getting a booster dose of the J&J vaccine. But it is very clear that we have a downward trend. And so going back to this high-level client journey, it's the social mobilization and demand creation that is the bottleneck, not the number of cubicles we have or the rate at which they work. The current policy is to take the vaccines to where the people are, not expect the people to come to where vaccination centers have been set up. So there will be a lot more activity of mobile sites and pop-up sites, perhaps associated with key events, sporting events, or social grant payout days. More complicated process, more demanding on the supply chain, more demanding on the pharmacists who take responsibility for the vaccines themselves. So, do you have questions? We've rushed through this, I realize, like machine guns, but we wanted to get the story told and allow a good time for any questions.
That's brilliant, because there were a couple, one which you were able to answer, or Dominique answered in that slide about wastage. And I really think that we should do a round of applause for zero wastage per day. I think that's just absolutely phenomenal. And quite rightly, be very proud of yourselves. Gareth asked the question, I can't read it now. Hang on. Was the pause real-time communication planned from the outset, or was it added later from the various learnings?
It was added.
It was added.
This site has a really interesting composition, unlike any other I'm aware of. Obviously, being at the CTICC, there are CTICC staff involved, and they were primarily involved in managing the outside queue and access into the building. Once in the building, Discovery Health took over. They ran the screening and the registration desks, and they contracted what they called wayfinders, and I think we more routinely talk about queue marshals. So we had CTICC, we had Discovery, we had queue marshals on contract. The Western Cape Department of Health employs the nurses and pharmacists who are involved. Contract security on site, just numerous different parties. So this was a really extraordinary collaboration of private-public partnership. And the site manager, bless her heart, Letitia, will say that she's the only person who's on a permanent contract. Everybody else is on a 6-month contract, including Dominique, including all the nurses, including the wayfinders, including security. And so it was a coming together of people who didn't know each other on the 7th of July. Everyone was a stranger to everybody else. And they probably looked askance at these Lean Institute people who didn't seem to know anything about medicines or vaccines or anything else, and yet were poking their nose into every part of the process. And it just, someone like Dominique was really up against it early on. People didn't realize how blind she was to the numbers in the queue. And yet she had this huge responsibility of the custodian of the vaccines. Mm-hmm. So no, it was not clearly understood at the beginning.
Yeah, and I can remember from one of the first presentations, I think it was the panel discussion that you did, they were talking about just the actual process and saving time by realizing that people actually wanted to celebrate the fact that they'd had the injection. And so therefore allocating somebody to take the photo rather than that person still being in the queue, taking up time. So moving them out of the queue and having their photo done to celebrate the vaccine. That's the sort of lesson learned that is just so practical.
Yeah, some of the timings that I did, I would stand at the point at which people were exiting the main hall, because that would give me a sense of the rate at which the whole system was working. And it was really quite emotional on occasions to realize there are people, young and old, flocking to the site, and the look of real happiness on their faces as they came out of the vaccination area, out of the observation area. It's been a great privilege to be involved.
And Gareth, thank you very much for the engagement, Gareth. What insights now I've lost you. What insights have you had about solving the demand creation problem? Good question.
Yeah, it's not something in which the Lean Institute has any expertise. It's a marketing problem, first and foremost. And I think the name Digital Vibes comes to mind as one of the big scandals in this country, where money should have been spent in demand creation and money went astray. I did go and spend time, I think I observed on 2 or 3 occasions, and then went to talk to the people in the Overberg Health District, which has got one of the best vaccination rates, percentage of population vaccinated in the country, certainly in the Western Cape. And they have a very interesting strategy of often taking the vaccines to where the people are, working very effectively with the farming community, so that they would go to set up a clinic at a pack house. The farmers would bring their employees to the pack house on a schedule, just as they would bring their fruit. So the vaccinators had a very good idea of how many people were coming, very low wastage rates, very high productivity levels by the vaccinators. So that was a kind of obvious thing where you brought the people together with the vaccinators. And then also would, in a place like Hermanus, for instance, they would not have a clinic every day. They would have Monday, Wednesday, Friday. At smaller towns, it would be maybe only 1 day a week. But they would do pre-publicity. They would get the mayors of the towns involved. They would get other politicians involved. Everybody really cooperated and collaborated in putting out the message: come and be vaccinated. This is the day on which people will be here. Again, what I saw in Overberg was a community pulling together. Not-for-profits, churches, mosques, the works, really saying this is a job to be done. So I don't know how we create demand. And it is alarming, the stories one hears about yeah, the ideas that have led to some people being hesitant. I think we've got a real job on our hands here in creating that demand. What do you think, Dominique?
I'd like to add to that. So yes, we've been here for a few months, but we are at the stage now where, as we previously mentioned, we need to take the vaccine to the people. We need to start educating people. And I know, like at our site, for example, we're going to one of our tertiary hospitals. There are patients there, so there could be a numerous amount of factors why patients are still either anti-vax or hesitant. So I think we are now at a stage within the vac, whether it's just in South Africa or over the world, where we now have to be the ones to go out into communities, educate people. And you know, the funny thing is, I have this conversation with some people or patients or clients, and you know, it's factors, it's things like, oh, I don't trust the government, or I don't trust, but they trust healthcare workers. So we need to be the ones going out there. We need to be in collaboration with our religious groups, etc. People that are trusted within communities. So I think really that's the only way going forward, because we won't be seeing feet coming to sites anymore. The feet needs to go. We need to be the ones to go now.
Yeah,
good point.
It was also said to me in the Iaphl district was that people will listen to the nurse, they will listen to the health worker.
Yeah.
It's a much more credible voice than anyone else.
Yes, absolutely. And Anita obviously has a lot of inside knowledge. Yeah, I was going to say the VUMA weekend, the VUMA vaccine weekend program. I understood that was supposed to start at the end of October. So already that's it sort of started with but it didn't start with a VUM. So hopefully it will now boom. But thank you, Anita. Anita's saying that the vaccine hesitancy is one of the top agenda items on the COVID vaccine rollout agenda, which, you know, is good to know. But I think it's up to all of us as well, those of us who have had the privilege of having the vaccine and who do understand the importance of it. There's so much negativity being done by social media, and you know, back in the Second World War, there was that thing about careless talk costs lives. And I think that that's you know, again, we've got to try and counteract that careless talk. There's another question from Gareth here. How will you adapt what you've learned at the CTICC to the mobile sites? Do you think the process flow will be very different?
It's the only way we've learned is by going to see. And I visited 2 what we call pop-up sites early in July. We were involved in experiments which were national, where on social grant payout days at Boxer stores and some other stores, there were sites. And yeah, I think we can learn from how those sites operate. Because again, each of the sites that I saw, I think there were 3 different ones, each had their own operating procedure and would do things differently, and try to understand which aspects work well and where can we learn from each other. Gareth, that's the way we've done this thing, is we've learned by observing and collaborating with the many people. Really, I must say again, it's been extraordinary, the commitment of so many people across so many disciplines and professions, and in particular the nurses who give the injections. They've got to give the conversation, engage with the person in just a few minutes to deliver a quality service, time and time and time and time again, which they've done cheerfully and professionally.
Yeah, I again, you know, Norman, you're always such a great champion of the team and of everybody in the team. Nobody is more important than the other, and I think that, you know, your your way in which you communicate it is just so real. So thank you very much for that. Very quickly, because we are on the top of the hour, I would like to ask you, Norman, in very few words, and Dominique, what's been your biggest, most important takeaway from your experience with this so far?
Okay, I'm going to give Dominique a moment. I was thinking of passing it immediately to her so that I would have the moment. But I think I've learned an enormous amount observing Letitia Saville, who is the manager of the CTIC site, observing her patience. So she understood that this team needed to come together. She understood that people would come together. She trusted that the team would gel and that the job would get done. And I think she taught me a great deal about patience. Over to you, Dominique.
I think the biggest takeaway for me, in such an historic, type of program, and just being a part of it, has really been the collaboration and just what we can accomplish if different people from disciplines, or even like in our case specifically, where we have the public-private collaboration, just what we can accomplish. And yes, I think that has been the biggest thing, and that you can't be rigid in your system, because every day is not the same year. So there needs to be this constant adjusting. So whether we have SOPs in place, there are days where things don't always go according to plan. So you need to have protocols, and just take the initiative and get the job done. At the end of the day, we are all here. Our main goal is to get as many people vaccinated, and I think that is what's special about this team here, is that every week when we have our meetings, that we don't forget why we are here, and that is to get our people vaccinated.
Brilliant. Brilliant. Well, on behalf of all of us, to you, thank you very much for all you do, but also to everybody in the audience. I just want to say a really big thank you to everything that you all do as well. I say it every time, supply chain professionals are exceptional, and supply chain professionals who work in the health space and the public health space, even more so, because you save lives. So thank you very much for all that you do. Thank you for being here. Norman and Dominique, big thank you very much. There's lots of thanks going on in the comments. So thanks very much. And I look forward to seeing you all on the next one. And we will do a follow-up email with all the detail about the next one, IAPHL membership, the link to Leah, and also information about SAPICS. So thank you all very much indeed. Take care, keep being brilliant, keep doing amazing work, and thank you all very much.
Thank you. Cheers. Bye.